privileged to present Dr. Hossam Debian. He's an oncologist of intervention and radiodiagnosis, and he is a dear friend and colleague of mine. Go ahead.
Thank you, Hossam. Okay, thank you. Locoregional ablation for treatment of HCC. HCC is the second most common cancer and third cause of cancer-related deaths. Liver resection and transplantation remain the cornerstone for patients with early-stage disease and represent the only option for potential cure in HCC. However, due to multinodularity of the tumor and the location, precluding curative resection and insufficient liver reserve due to underlying chronic liver disease, the reported resectability rate is low. Locoregional therapies are integral to the management of HCC patients who have unresected disease or those who are deemed unfit for surgery, unresectable Barcelona clinic liver cancer, and A and B disease. We can perform with the curative, downstaging, bridging, or palliative intent. First staging, given the close relationship between HCC and cirrhosis, the classic staging system commonly used in oncology are inadequate for obtaining a correct prognosis, stratification, and appropriate consequent allocation for therapy. For this reason, we have two systems, evidence-based medicine and Barcelona clinic level cancer staging system. This system, which is now applied in the world, take into consideration the stage of the tumor, dimensions, vascular invasion, and distant metastasis, but also liver function according to the classic stratification using the patient, child, BOF, and the PS score. This is the HCC staging. The first line for treatment is surgery, surgical resection or liver transplantation, and second we will call about chemical ablation, and then energy-based ablation, transcatheter ablation, radiotherapy, and systemic therapy. First, we will talk about ablative therapies. We have chemical ablation, percutaneous ethanol injection, thermal energy-based ablation, RF, radiofrequency, microwave ablation, and cryoablation. It's not found in Egypt, but you are waiting for it. Non-thermal energy-based ablation, irreversible electroporation, laser-induced interstitial thermotherapy, and HIFO, high-intensity focused ultrasound. The use of the ultrasound or CT-guided technique is dependent on the operator performance, the availability of imaging equipment, and the optimum visualization of the target lesion in the selected imaging modality. We can use just ultrasound or another modality, CT or MRI. Chemical ablation, percutaneous ethanol injection. It was the first ablative technique used in clinical practice for treating early stage HCC, where absolute alcohol is injected into the tumor. Ethanol diffuses into the cells, causing cellular dehydration, protein denaturation, followed by fibrosis and small vessel thrombosis, thereby inducing coagulative necrosis of the tumor. Tumor targeting may be challenging as the treated tumor margins are less distinctly defined, and such as prolonged treatment and multiple sessions may be necessary to induce complete tumor necrosis. Thermal energy-based ablation. The objective of this technique is the ablation is to induce coagulative tumor necrosis using extreme temperature, more than 60 or less than 40. Thermal ablation ablates both tumoral and peritumoral tissues, with the aim of inducing an adequate margin, about 5 to 10 millimeters, around the tumor to eliminate surrounding undetected microsatellites. And these cancer microenvironments are frequently found in HCC more than 2.5 centimeters, which might account for the suboptimal efficacy of ablation over this size of threshold. Percutaneous image-guided ablation has become established in the treatment of patients who fall outside of treatment criteria for surgery or performance status. Ablation carries a low risk of complications, mortality due to minimal invasive nature. This is the machine for radiofrequency ablation. different radio frequency ablation systems: Generator, Application, Valley Lab, Boston Scientific, and Angiodynamics. Radio frequency ablation utilizes the principle of an alternating electrical field to generate RF waves, which dissipate their energy within the surrounding target tissues as heat. This is achieved by alternating electric current causing ionic agitation, generations, frictional heat. Eventually, coagulation necrosis of the target tissue is reached. In this case, the CT, radiofrequency ablation of an HCC. The probe is initially inserted within a single tap into the lesion. Once a satisfactory position is achieved, multiple times can be extended into to achieve an appropriate size ablation zone. This is another case, a 58-year-old male with HCC and segment 5, treated with radiofrequency ablation. This is the ultrasound image shows the lesion prior ablation, and the MB ultrasound image during the procedure show the intralesional echogenicity from the tissue burning. This is another case, ultrasound-guided RF ablation of HCC, MRI with contrast, arterial intake, and this is the ultrasound. This is the RF needle, demonstrating RF needle within 3 centimeter exposed tap crossing the lesion. And then follow-up, 1 month follow-up, portal venous phase, demonstrating oval-shaped ablation zone arm. Microwave ablation is the aim to achieve coagulative necrosis of the target lesions by alternating electromagnetic waves into the spectrum between 900 and 2045 megahertz, taking advantage of the asymmetrical polarity of the water molecules. Alternating electromagnetic waves cause adjacent water molecule to flap 2 to 5 billion times a second, resulting in frictional heat that is required to achieve target temperatures. What the difference between radio frequency and the microwave counterpart? There are no multiple arrays, although systems do exist where several separate probes can be attached to the and inserted. The ablation zone may be elliptically shaped or spherical depending on the system they selected. Additionally, the center of the ablation zone may be located proximal to the probe tip or near to it, depending on the way of the technology has been implemented. The microwave ablation of the liver tumor. The antenna is placed percutaneous into the tumor mass before microwave energy is applied to heal the tumor to cytotoxic levels. We have different cases. This is the microwave needle. We have echogenicity by ultrasound. Another case. And the third case is multiple echogenicity within the lesion. Okay. This is another case for microwave, the lesion, and at the CT. Microwave needle within the liver during treatment. Low attenuation. We have low attenuation surrounding gas generated during thermal coagulative necrosis, and the dark band proximal to the needle tap indicates central point at which the ablation zone will be generated. Cryoablation, we are waiting here in Egypt to be present in Egypt, relies on alternative freezing and thawing to destroy tissues. This technique is based on Gould-Thomson effect, where compressed argon gas is forced through the tap of the probe, rapidly reducing the pressure and temperature. As a consequence, ice crystals form in intra and extracellular spaces, drawing water molecules to either side of the cell membranes to form crystals and causing irreversible damage to the membrane and other cellular structures. This is the ice ball on the ultrasound and also by CT. The advantage of cryoablation will be visualization of the ice ball either by CT, MRI, or ultrasound, no severe pain, and lack of severe damage to large vessels, lack of severe damage to the gallbladder. Non-thermal energy-based ablation, irreversible electroporation, is a new technology that relies on the production of ultra-short but strong electrical fields to create nanopores in the cell membranes, originally developed at a reversible state to deliver DNA and other potential mid-clinical vectors into the cell. It was realized that increasing the electrical field lead to permanence of the pores in the cell membranes, disrupting cell hemostasis and inducing apoptosis, in contrast to coagulation necrosis induced by thermal ablation methods. Unlike thermal ablation, spares the extracellular matrix and the collagenous tissues, example large vessels, biliary tract, making it as attractive option for these lesions near sensitive structures, particularly near the liver, hilum, colon, and gallbladder. At least two needle placement in parallel are required around the target lesion to form a circuit through which the electrical current is delivered, with an optimized needle distance of 2 centimeters. Larger lesions requires more needles to maintain the 2 centimeter maximum distance with maximum of 6 needles. Each needle combination is tested to ensure the appropriate current. In this case, we have HCC near the portal vein and biliary radicals after treatment, resulting in successful ablation zone with no collateral damage. You can see in this picture. This another case, complete ablation after single procedure for infiltrative HCC. Near also near the portal vein with partial portal vein thrombosis. In another case, complete ablation for single procedure, 6 electrodes for nodular HCC next to the left portal vein branch. This case is close to the portal vein and no damage to the portal vein. High intensity focused ultrasound, HIFO, is non-invasive hyperthermic ablative modality by multi-element ultrasound transducer positioning outside the body or in a cavity that target a focal area of high intensity ultrasound beams. The convergence of these beams causes an increase in temperature to approximately 60 to 85 degrees, inducing tumor cells coagulation necrosis together with cellular apoptosis in the surrounding tissues. Laser ablation, non-invasive technique also, in which the laser optical fibers are focused in the target lesion, leading to temperatures of over 60 degrees, causing coagulation necrosis when applied in a minimal invasive modality to reach its deep tissues. This compared بين radio frequency and the microwave, cryoablation, freezing, and irreversible electroporation. Complications of liver ablations, hemorrhage, intraperitoneal or liver parenchyma, biliary damage to biloma or bile leak, thoracic injury, diaphragmatic perforation or pneumothorax, gastrointestinal perforation or thermal injury, liver abscess, liver abscess, portal vein thrombosis, tumor seedling, and skin burns. Non-target organs injury is unusual and not well described in the literature. Thermal energy to the surrounding organs in most cases of GITs should be avoided by reviewing previous planning or staging scans. It may be possible to dissect bowel away from the potential ablation zone using 18 gauge needle and 5 injection dextrose solution. Otherwise, reconsidering the appropriate thermal ablation against another treatment modality. A further consideration for this lesion is adjacent to the large vessels, where the thermal energy at the treatment site can be diminished by heat sink effect, resulting in a less effective treatment and necrosis of the tumor. The tumor seedings through the ablation is insignificant, possibly if tract ablation is not carried out. It's very important for the tract ablation before, after the therapy. Thank you.
Thank you so much, Dr. Hossam, for this very nice presentation.